A 28-year-old male with obstructive jaundice was found to have portal cavernoma with biliopathy and bilateral intrahepatic stone. In the absence of shuntable vein on ERCP biliary sphincterotomy, there was bleed which was controlled with 4 cm fully covered SEMS. After that, there was recurrent cholangitis requiring percutaneous cholecystostomy and multiple plastic stenting. Endoscopic band ligation was done after cholangitis subsided. Prior to band ligation, US showed pericholectal collaterals with perforating veins leading to intracholectal varices along with stent and stones in situ. 2 months later, he presented with cholangitis, and after multiple plastic stenting, he was taken for surgery. However, in the absence of shuntable vein, attempted hepaticojejunostomy led to torrential bleeding, so the procedure has to be abandoned only after cholecystectomy. A longer fully covered SEMS was advised prior to reattempt of surgery. After removal of SEMS, paroral cholangioscopic electrohydraulic lithotripsy was performed for large common bile duct and hepatic duct stones. Patient continued to have fever after putting 6 cm fully covered SEMS, which did not subside even after putting nasobiliary drain. Hence, cholangioscopy was repeated through SEMS, which showed an impacted bile duct stone above the stent, for which second session of electrohydraulic lithotripsy was done. This was followed by EHL of hilar and intrahepatic stones. A double pigtail anchoring plastic stent was placed to secure the partially migrated fully covered SEMS. The patient was planned for surgery after 3 months. Patient was afebrile for 2 months. Then he had a spike of fever and came for follow-up. And a repeat cholangioscopy was planned through the SEMS, which was partially migrated outside. Just above the upper margin of the stent, narrowing could be noted along with stones, for which electrohydraulic lithotripsy was performed. You could also see some fragment of earlier plastic stent that was placed earlier. During the attempted lithotripsy of these stones, a minor bleeding started from one of the adjacent varices, although it stopped spontaneously. Large stones were fragmented into small pieces. Lithotripsy was continued further from the CHD towards the hilum until all the large stone fragments could be broken into smaller pieces. This is towards the hilum. A small varices was seen along with some blood overlying it, which was initially confused with a stone. However, carefully, lithotripsy was avoided adjacent to the varices and only done for the adjacent stones. This is the varices that probably bled during the initial attempted lithotripsy. However, the bleeding stopped spontaneously. Most of the large stone fragments were pulverized, and then we planned to remove the metal stent so that we can balloon sweep all the stones. After SEMS removal, a persistent stricture was noted in the mid and lower CBD, along with few filling defects in the CHD and left hepatic duct. Balloon sweep was done several times, removing small stone fragments one by one. Then complete stone clearance was achieved, which was confirmed by a cholangiogram. Cholangiogram showed no stones inside the bile duct with persistent distal and mid CVD stricture. A 6 cm fully covered SEMS was placed along with the anchoring plastic stent to prevent migration of the stent. Fully covered SEMS and parallel cholangioscopy guided lithotripsy can be used to manage stricture and intractal stones respectively when shuntable vein is not present in portal cavernoma cholangiopathy, as highlighted in this case where surgery failed due to intraprocedural bleeding during attempted biliary bypass.